Good morning. My name is Carolyn Bates, and it's my distinct pleasure to welcome you to the Dr. Leone Mattioli lecture. I'd like to welcome everyone here in person and everyone viewing from all of our various locations across KUMC Pediatrics and Children's Mercy. Before we introduce our speaker today, we have a few housekeeping remarks. If there are questions for the presenter, attendees should use the question and answer function in Teams, and they will be asked at the end of the presentation on their behalf. This Grand Rounds is approved for continuing medical education credits and for continuing education credit for radiology and imaging professionals. The Cloud CME platform is used for capturing attendance and for the evaluation of Grand Rounds. Today's activity code is 5791. Instructions are available in the Teams Q&A function. Following the lecture, please complete your evaluation by logging into the CME platform or using the link emailed to you. The evaluation is required for continuing education credit. The Leone F. Mattioli Lectureship was established in 2009 to honor the life and work of Dr. Mattioli. Dr. Mattioli was a professor of pediatrics at KU Medical Center and the first clinician in Kansas to use telemedicine to deliver care to children. He was an expert in the diagnosis and management of cardiac disease in infants and children with a special interest in medical education. He won numerous awards for teaching and mentoring, including the Student Voice Award, the Kemper Award for Teaching Excellence, the Cheng Cho Award for Excellence in Pediatrics, and the Lifetime Achievement in Mentoring Award, also known as the Jayhawk. Dr. Mattioli is remembered as a lifelong learner and a dear friend to many of those in the Department of Pediatrics. At Grand Rounds and other presentations, he took copious notes and was usually the first person to ask a question or provide comments. Even after he retired from clinical practice, he continued to teach students and residents on a regular basis. He was also an inspired collaborator in clinical and basic science research, bringing to the wet lab a continuous series of questions concerning cardiac physiology. Dr. Mattioli inspired generations of students and colleagues by virtue of his great curiosity, kindness, sense of humor, and love for children and his fellow man. This year, we have an excellent speaker to honor the long and important legacy of Dr. Mattioli. Professor Stephanie Kraft is an assistant professor of pediatrics at the University of Washington School of Medicine and the director of research for the Treuman Katz Center for Pediatric Bioethics at Seattle Children's Research Institute. Professor Kraft received her BA in economics from Stanford University and her JD with a concentration in law and health sciences from the University of California, Hastings College of Law. She completed a postdoctoral fellowship in bioethics at the Stanford Center for Biomedical Ethics. She is a lawyer, bioethicist, and mixed methods social science researcher with a scholarly focus on improving patients' and participants' experiences with clinical and translational research and the equitable clinical implementation of emerging technologies. Professor Kraft's current research projects are funded by the National Human Genome Research Institute and the National Center for Advancing Translational Science. These projects aim to promote respectful and equitable research recruitment and to integrate community values into the development of artificial intelligence-enabled mobile health tools. Today, she will be speaking to us about advancing trustworthy research, building respectful relationships, and addressing inequities throughout clinical research. Please join me in welcoming Dr. Kraft.
Well, thank you so much for that introduction. Can everyone hear me okay? And for inviting me here today. I'm really pleased to be here and pleased to see so many people in person. Although I did hear that I missed a parade yesterday. So, maybe next time. Just start, I have no disclosures to make. And I actually want to start with I moved my acknowledgement slide up to the front because I wanted to start off by thanking all the many people who made this work possible. Starting first and foremost with the many research participants who contributed to the studies that I'll be sharing with you today. I do a lot of empirical work and I would not be able to be here presenting this without all of their contributions, their time and their effort and their perspectives. I also want to thank the members of our parent advisory panel who have contributed to the development of the intervention that I'll share toward the end and have really shared a lot of their own perspectives of having their children hospitalized and being open and honest and sharing their time and perspectives with us. I want to acknowledge my co-PI on a couple of the projects I'll be talking about today, Dr. Elliot Weiss, as well as Dr. Sunny Jewell and the Divi team, who have allowed us to work with their team to implement some of our efforts to improve recruitment in the setting of neonatal clinical research. And then a whole list of other people who have provided mentorship, collaboration, support of various types and sorts, and then also to thank my funders, particularly the NHGRI, which is funding the K Award that is providing support for a lot of the work that I'll be sharing today. Okay, so today I'm going to start by exploring and talking a little bit about why we should care about the constructs of respect and trustworthiness and thinking a little bit about what these mean. I'll then move into how we in clinical research have traditionally thought about the principle of respect for persons and what some of the limitations of that traditional approach are. From there, I'll move on to share some empirical findings about how participants want to be respected and what their expectations are for how we treat people during the research process from the moment of recruitment throughout the entire research process and follow-up. And then I'll share empirical data from researchers who are engaging with participants to explore how they think about relationship building, what some of the barriers and facilitators are. And then we'll share some intervention work toward the end about how we can support researchers to form better and more respectful and equitable relationships with research participants. And I'll wrap up thinking about where we go from here, what some of the remaining gaps are, and I hope that we can have a good discussion about how you might see some of this work adapting into the context in which you all work. So I want to start with this quote from Dr. Consuelo Wilkins. Dr. Wilkins is a leader and an expert in equitable clinical research, and particularly in the area of community engagement. And this quote comes from a paper where she's exploring what our obligations are, not just toward research participants, where we have some regulatory protections, albeit somewhat limited, and I will talk a little bit later about what some of those limitations are, but also toward the community members and the broader groups of stakeholders that we engage with in research. And one of the points that she makes is that we really need to be thinking broadly about how we are engaging with folks and thinking about participants and the participants, the patients, the community members, and other stakeholders who are asking to engage with us and asking to trust us. And it's our responsibility, our obligation as researchers to make ourselves worthy of that trust that we're asking people to place in us. And this is especially important, right, because the research systems and the healthcare systems that we're all a part of have a long history of not acting in ways that are always trustworthy and causing harm to many people, particularly to people from marginalized communities. And so as we move forward and try to work toward a more equitable research system and a more equitable healthcare, Dr. Wilkins writes that we must place greater emphasis on being trustworthy and creating a culture that is inclusive and mutually respectful. And what I want to do today is dig a little bit into what this means to create this culture of inclusivity and of respect. And one place that I want to start and really spend a lot of time focusing is this idea of building respectful research relationships, which I think can be a way of starting to develop that culture and can also have very tangible impacts for the individuals who we're forming relationships with. So a respectful research relationship can be a helpful way of promoting transparency in the researcher-participant interaction. So much in the same way that we think about shared decision-making in the clinical setting, we can think about a shared decision-making in the research setting where we want to be engaging with people about the risks and the benefits of research at the same time as we're exploring their values and supporting people in making a values-based decision. This same transparency can also help researchers to identify and address potential access barriers and reduce potential risks of harm. By being more attuned to the things that people are facing in their daily lived experiences, we can be better able to identify what these barriers are, the types of things that might be getting in the way of people having research opportunities, and also potentially causing harm throughout the research process and addressing those. And so by paying more attention to these things, by being open to hearing what folks have to say, and by giving people the space to say those things, then we can identify and address those. And then by forming a respectful research relationship, we can begin to signify that there's a potential for trustworthiness here. And I know I'm using a lot of hedging language in this sentence to signify the potential for trustworthiness, but I do that intentionally because I don't want to imply that by forming, by having one positive interaction, forming one relationship, that makes somebody trustworthy, because it's not that simple and it takes a long, ongoing process. But I do think that this is a step down that path, and that by engaging in a respectful relationship, by embarking down that path, we can start to work toward that goal of trustworthiness. It's also important to explore who we're talking about, who the object of this respect is, and why and where those obligations come from. So at its most baseline level, everybody is deserving of being treated with respect. We're all human beings. We all have a right to be treated as an ends in ourselves and not as a means to an end. In the context of research, research participants who have accepted the risks and the burdens of participating in the research in order to benefit others, we as researchers owe a heightened responsibility toward these folks because of that relationship and that vulnerability that they have entered into. And I think this also extends to potential research participants, right? So if we are holding out our hand, asking people to make themselves vulnerable, to accept these risks and burdens, we also have to be offering our heightened obligations toward them. And I would also suggest that we should be thinking about not just respecting the individuals who are engaged specifically in our studies, but the individuals and the communities who are likely to be affected by research outcomes. Now, our obligations toward these folks will be a little bit different than when we have that direct research interaction. But I think we need to be thinking really critically about how the findings of our research are going to be implemented, what impact that might have on specific patient populations, on broader communities of people, how results might be used or potentially misused on a broader scale. And so I think we need to be thinking about these obligations as well. Okay, I want to focus in now on how we traditionally think about respect for persons and what the existing regulatory structures are in the context of clinical research. And so the Belmont Report, which is the main guiding document for research ethics in the US, lists respect for persons as one of the 3 guiding ethical convictions. And they state that it incorporates at least 2 ethical convictions. First, that individuals should be treated as autonomous agents. And second, that persons with diminished autonomy are entitled to protection. And now what this has effectively done over time is really focused our principle of respect for persons in on this idea of respect for autonomy. And over time, that has led to a strong emphasis on the informed consent process as the main way through which we think about trying to promote autonomous decision-making. And informed consent is, of course, an important part of the research process, but it also comes with lots of limitations. There are many instances where we are not actually getting informed consent. There might be emergency research situations. There might be, to use a regulatory term, it might be impracticable to get somebody's consent. And then when we're working with children or people with cognitive impairment, they may not be providing their own consent. In some cases, they'll be providing assent, but in other cases, they may not be able to do that. And so we need to be thinking more broadly about how we're engaging with and respecting people in these contexts where we're not always getting consent. And even if we are getting consent, there are a lot of limitations to that too. I'm sorry that this slide is so fuzzy, but what this is showing is that this is showing results from a meta-analysis of participant comprehension of components of informed consent across clinical trials. And essentially what it's showing is that comprehension is somewhere in the neighborhood of 50 to 75%. So about 50 to 75% of participants are understanding each of these different elements of consent. So things like the nature of the study or the fact that participation is voluntary, those are closer to 75% of people who are understanding those. But for concepts like placebos or randomization or even being able to name at least one risk, those are much closer to 50%. So, there's not really agreement on what proportion of understanding is required, what proportion of people understanding each element is required. It's probably not realistic to expect that to be at 100%, but I think we probably can be doing better than these numbers. But at any rate, this illustrates that, we're somewhat limited in how much people are actually coming away with from the informed consent process as it currently stands. To complicate things further, it may actually be that people are not relying on the informed consent process to make their decisions. So this is a chart from a study that my colleagues and I published a couple of years ago, where we surveyed parents about how they made their decision or when they made their decision about enrolling or not enrolling their child in a behavioral health intervention study. And across both people who declined to enroll and those who did enroll, what we found was that about a third of people said they made their decision before they even had any contact with the study team. So they had either heard about it from their doctor or they received a flyer in the mail and they pretty much made their decision at that point. Another third of people made their decision after having an initial phone screen with someone from the study. So they hadn't walked through the details of the study, but just had that initial eligibility screening call. The remaining third made their decision at some point after having received the consent form, although of these, only a very small number said that they decided after having read the entirety of the consent form. And so it becomes clear through this that even if we're focusing on promoting autonomy, promoting autonomous decision-making, we're missing a lot of the time and a lot of the ways that people are making their decision by just focusing on the consent form. And I don't mean to suggest that we should do away with consent, because it certainly, for a chunk of these people, it seems to be supportive of their decision making, and it does provide other functions. But if we're thinking about how to promote autonomy, then we need to be thinking about this entire process. And more broadly, if we're thinking about the principle of respect for persons, not just respect for autonomy, I think that we need to be thinking even more broadly. So in reflecting on all of this data about informed consent, I like to revisit how I'm defining what respect means. And I like to use this definition that comes from Neil Dickert's work, who has written a lot on how we think about the principle of respect. And he says that respect is marked by the combination of appreciating what is valuable or important about a person, recognizing the constraints or demands that places on one's own conduct, and acting in a way that expresses that recognition. So here we're really focusing on respect, not just in terms of supporting that decision, but recognizing a person, a whole person, and all the things that make them a unique individual. And then in turn, identifying the ways that we can meet our obligations toward them and following through on that. And I think this nicely aligns with a more relational approach to research ethics than we have often traditionally thought about. So this is a framework that comes from work by Cassio and Racine, who call this a person-oriented research ethics. And they identify these 5 elements of a person-oriented research ethics that I think align with the way that I think about how we ought to show respect for people during research. So they talk about respect for holistic personhood, so seeing people as whole human beings. Acknowledgement of lived world, recognizing what people's lived experiences are on a day-to-day basis. Individualization, so seeing people as unique individuals. Focusing on researcher-participant relationships, and then empowerment and decision-making. And so I'm going to continue talking today, really focusing on researcher-participant relationships, but in doing so, I think these relationships can encompass all of these other elements of this framework too, and I think this provides a really helpful refocus on how we think about our traditional perspective on respecting people in research. And as we think about research relationships, I also want to be clear that these relationships, our paradigmatic view of a relationship is an individual one, right? So we have this individual researcher and an individual research participant. But of course, that individual researcher is situated within a team and situated within a research institution. And there are various actions and policies and practices and people in all of these stages that really inform how those relationships are developed and supported. And so we need to be thinking about not just that individual relationship, but how things at the institutional level, for example, might be impacting that and might be impacting the ways that an individual participant interacts with the research institution as a whole. And I don't have this up here, but they're also, you can imagine a similar and probably much more complex pyramid on the participant side, right? So people are not making their decisions in a vacuum either. They're embodied in this lived world in which they live. And this pyramid itself, is even more complicated than this in reality, right? So we have research sponsors who are funding the research, who are deciding what the priorities are for research. And then we can also be thinking about the role of society at large in all of this and how that plays a role in shaping what these practices are on the institutional level. So far, I've been focusing intentionally on the researcher's side because, as I said at the beginning, the onus is really on the researchers to make ourselves trustworthy. But in doing so, we also need to understand where participants are coming from and how they want to be treated, what their expectations are for how how we interact with folks in research. So I want to share some of our empirical work with research participants about how they perceive the principle of respect and what kinds of actions they see as respectful or not respectful in the context of a research study. So this was a qualitative interview study that we embedded into a broader genomics implementation study. And so we interviewed 40 participants in both English and Spanish about how they experienced respect in research. And we identified through these interviews 4 overarching domains of respect. So first, people talked a lot about personal study team interaction. So this is that individual relationship. They talked about the importance of being approached with empathy, of being shown appreciation for their contributions, and of being approached without judgment. And this was particularly important in the context of a study where they might be collecting personal information, they might be collecting family history information that people may or may not feel comfortable sharing, but just really approaching this in an open and non-judgmental way. Second was the communication processes on the overall study. So even beyond that initial interaction, what kind of ongoing communication is there? So what kind of options did people have for participating? Were there different ways and different adjustments that people could make to their participation? Was the study team responsive? Did they follow up in the time and in the way that they said that they would? And then did they share results back at the end? So lots of different ways of continuing that engagement from that initial connection. Third was inclusion. And so here people were really talking about the importance of the study design overall and the way that the protocol was designed to be inclusive and accessible. So some of the things that people pointed out specifically were that this particular study had made efforts at inclusive recruitment by reaching out to clinics where there had not previously been a research presence. And so people said, we haven't been asked to be in research before because there are researchers at our clinic. And so this study made a point to be doing that recruitment in those settings. The materials were understandable and written specifically for the patient population. And the study procedures themselves were accessible. So this actually was, we did all these interviews before COVID when hybrid research wasn't so much of a thing. But one of the things that people pointed out was that, on the one hand, some people said, I really like that I can come in person and have someone walk through everything and walk through the whole consent process with me. Other people said, I work, I can't come in during business hours, so I appreciate that I can do the entire study online and I don't have to come in, I don't have to take the time. And one person actually talked about having social anxiety and how participating would not have been an option for them if they had been required to come in person. And then finally, consent and authorization is a piece of how people perceive respect in research. So like I said, consent is still important, but it has to be viewed in context of all these other things as well. So here people talk about the importance of having information provided in a neutral way, being presented transparently, and then also having robust privacy protections in place and having those explained very clearly. And I like to really boil these down by thinking about them as these 4 stages. So starting with building relationships, in those interpersonal connections, maintaining those relationships through the communication processes, throughout the entire process, and really in the stage of study design and protocol design, addressing unjust structures and responding to accessibility and inclusion barriers, and then promoting autonomy. After we've kind of gone through all of those other steps, we can really focus in on promoting autonomous decision-making. I just want to highlight this one quote from this study that I think really encapsulates what a lot of our participants said. And this person said that for me, it comes down to how they treat me. They don't treat me like a patient. They don't treat me like a number. They treat me like a person. And I think this is important because it highlights both this idea of not being treated like a number, but also not being treated like a patient. And I think this is really important for researchers to keep in mind that people are often coming from a place where they have had negative clinical interactions in the past, and the research relationship can be a way to kind of start that anew. This is a busy slide, but I just wanted to share some preliminary findings that are following up on this qualitative work. So we did a follow-up survey using the consensus building Delphi technique with patients who were not currently enrolled in a research study to explore how they thought about or which of the activities identified by our interviewees were most important for conveying respect. And so just to briefly highlight, the findings or the items related to informed consent and relationship building were the things that kind of rose to the top. But it's also important to highlight that all these other things that are not necessarily related to those relationships or the consent process, like having somebody speak the person's language, receiving their individual or their overall study results, all of these things were also, right up here close to the top. And so what I think this illustrates is that these research relationships and the informed consent process are really critical, but they also need to be scaffolded by these other respectful actions. And so we don't want to be limited in thinking about, and thinking that there's only one way to demonstrate respect, but we can be thinking much more broadly and building as many of these actions into our protocols as is possible. And in doing so, as I pointed out in that quote a moment ago, and we can recognize the impact of people's lived experiences, their prior clinical interactions, and begin to build a new research relationship. And through that research relationship, we then can begin to demonstrate respect and trustworthiness over time. So I now want to focus in on that question of how we build that research relationship, so how we start those new relationships. And so I specifically want to focus in on the role of research staff. So by that I mean research coordinators, research associates, research nurses, the people who are doing the frontline recruiting and consenting and really engaging with potential participants. And we know this is a really critical role, but there's not a lot of guidance out there to support people in building relationships. And in fact, there's not really much robust, training or support for people in this role. And so we conducted a qualitative interview study with research coordinators about how they approached relationship building, which was recently published. And our goal was to describe the barriers and facilitators that they faced and identify places that we could support relationship building during the recruitment process. I just wanted to briefly highlight our participant demographics. So we talked to 28 research staff members and specifically wanted to highlight the research settings. So we tried specifically to talk to people across a number of different pediatric research settings. And so that's represented there. Through our interviews, people really spoke about the relationship building process in 4 stages. So first, before they even approached a family, deciding whether to approach and when to approach, and thinking about the clinical setting that the person was in, the other things that might be going on for them. Second was the initial connection, so meeting the family, introducing themselves, making sure they had the family's names and pronunciations and pronouns correct. And then addressing any potential needs that the family might have outside of the research context. So folks who were doing research in the emergency department talked about, making sure that families had something to eat before they even thought about talking about research. So things that seem pretty simple, but actually are really meaningful to participants during the relationship building process. After that initial connection, then they moved on to the building connection phase, and this is where people talked about the study with the family and engaged in that back and forth about the family's values and the options for whether they wanted to participate or not, and help them think through how they might, whether participation was right for them. And then finally, a key part that I think often gets forgotten is the follow-up. So keeping any commitments and engaging in an ongoing relationship building process, particularly for more longitudinal research, but even in shorter studies as well, making sure to keep those follow-up commitments. And then, of course, across all of these, our interviewees also talked about a number of factors at both the individual level as well as at the institutional and societal level. So individuals talked about the training that they may or may not have received, many times not, as well as their personal motivations for doing this kind of work. At the institutional and societal level, people talked about a number of different structural factors that were really informing how they went about their day-to-day work. So things ranging from the role of the IRB, the role of other institutional policies and procedures, the accessibility of translation and interpretation services, the impact of COVID, and various other factors across the institution and across society. And I want to walk through 4 of the key themes that we identified through this work, just to illustrate the way that these factors all play out and intermix with one another. So first was that, people talked about a number of tensions and supportive relationships between them and a variety of other actors, and these influenced their ability to perform their tasks and address challenges. So often people would say, I recognize that, I recognize a particular challenge. I recognize that many of our patients, for example, need childcare in order to participate in this research, and yet I'm coming up with all these barriers depending on who I talk to and how I'm feeling kind of stuck between different perspectives in terms of how to address that challenge. One of our participants said there's definitely a different power dynamic when it comes to PIs and their research assistants that adds an extra layer of being careful of what the PI says versus what the IRB or the protocol or the institution might say. Second was the integration and distinction from between clinical care and research. So this was something people talked about a lot, not necessarily as a tension, but something that they were trying to keep in balance. So they both saw the benefits of being integrated with clinical teams in order to support relationship building, but also the need to distinguish the research activities from clinical activities. So on the one hand, people talked about how a warm handoff from a trusted provider to a researcher can be very powerful in starting that research relationship. But on the other hand, they also talked about needing people to know that they're from research and they're not part of the medical team, so they don't have to worry about overstepping any bounds. Third was the focus on voluntariness, and really the research staff seeing their role as supporting people in making voluntary decisions and emphasizing the importance of voluntariness. This was not just a part of the informed consent process, but also a key part of the trust building and relationship building process. They saw this as a way of helping to reduce pressure on families and respond to the power dynamics in that researcher-participant interaction. So one person said, I've heard a few times people don't want to be a guinea pig, that sort of thing. I would try to let them know why we were doing this research and just stress that if they ever feel that way and they don't want to do it, they can change their mind at any point. So really acknowledging, that this is a voluntary decision as a way of building that relationship. And then finally, people pointed to inequities at multiple stages of the research process. This was during the recruitment process where most of these people were doing were focusing their work, but also pointing to a lot of things that happened upstream of where they were engaging with people. So for example, people's ability to access care in the first place. And then throughout the research process. So variable burdens of participation depending on somebody's socioeconomic status, as well as the existence of validated measures in different languages that made it that created limitations for who was eligible to enroll in the study. So upstream, they talked about getting to the clinic, the hospital, and seeking the care, all those other factors. And then downstream, or throughout the consent process, we run into the problems of having documents such as a consent form translated into all the available languages. And we're actually in the midst of doing a secondary analysis specifically on these themes around inequities and access barriers in research, because we really noticed that this was a prominent theme and something that people were really talking a lot about. And these kind of broke down into 5 stages of the research process. So beginning before there's even a research process, but with access to the clinical team in the first place, recognizing that the cost and things like referrals to specialty care are differentially distributed across populations, and so not everybody is getting equitable access to those places where they can then be recruited for research. Even if people are already in a clinic, the opportunities for research after that access to clinical care are also variable. So things like the geographical location. So we talked, a lot of folks from rural clinics or places or satellite clinics where there's not a strong research presence didn't really have the same kind of opportunities for research as folks at the main hospital's location. There are also inequities in the relationship building process with the research team, and here people talked about the importance of diversity on the research team, as well as the language skills of the researchers in order to engage with people and really explore people's values in their preferred language of care. During the consent process, again, people identified issues related to translations into different languages, as well as the complexity of the language and people's ability, as we saw earlier toward the beginning of this talk, people's ability to understand all the different elements of consent. And then finally, throughout the research process, even if somebody makes it through all these stages, the variable burdens of participation that fall onto participants and the existence of validated measures, things like whether we reimburse people for taking public transit just the same way that we might reimburse them for parking, and lots of other sort of research practices that can variably impact people. So taking away from this work, I think one thing that this project highlighted is that research staff are really uniquely positioned to identify both individual and systemic ethical challenges across multiple stages of the research process. So by being right at the front lines and engaging with participants on a daily basis, they're really able to identify not only things that are affecting individuals, but able to kind of say, hey, I'm seeing this same access barrier come up repeatedly time and again, and that can help us identify where we can do better. And so we need to be supporting research staff in advocating for structural change in research and ensuring that their voices are heard in the process of policy development. I think this work around equity also highlights that we need to bring a broad equity lens to analyze the inequities that cut across multiple stages of clinical research. And so not just focusing on one of those stages, but really thinking broadly about where we can change things at multiple stages and be kind of taking a multi-pronged approach to navigating these inequities. So, for example, are there local policies or practices that can be changed to help reduce some of the costs around translation or some of the burdens around reimbursement procedures? And then within the context of an individual research study, are there things that can be changed as well to help address some of those things? So thinking about how to support staff in building these relationships, I now want to move to some interventional work that we're doing that's building on this work, and it builds on some of the prior work that I shared earlier. And I'll share our intervention, which is called the Better Research Interactions for Every Family intervention. And this is an educational intervention that is targeted for the NICU setting. I'm collaborating with my colleague who's a neonatologist on this project. So we know that the NICU setting is a place where research interactions can be especially challenging. It's extremely overwhelming. There are lots of challenges to trust building, to relationship building. And we know that there are disparities in research enrollment across both demographics and across clinical status. So we've developed what we're calling the brief researcher educational intervention that's based on our prior findings about participants' perspectives on how they want to be treated with respect, as well as on how researchers and research coordinators approach building relationships. And we're currently piloting its implementation in a neonatal clinical trial, which is a single-center phase 2 trial to improve iron status and neurodevelopment. And our overall goal is to enable people on the research team to develop research partnerships that ultimately make the process better for families, improve their experiences of respect, and improve equity in enrollment. So our module was developed using the framework of intervention mapping, which builds on our prior research as well as other prior literature, and uses behavioral theories to support behavior change across these our 10 measurable performance objectives. So we anticipate, based on our prior work, that our performance objectives are going to improve respect and equity across our 4 stages of relationship building, which I just shared. So our objectives span these 4 stages, and we're trying to work with our researchers to teach these objectives and teach them to integrate those into their conversations with families. We have a bunch of pre-work, or a little bit of pre-work, not a bunch. A couple of videos where our patient advisory panel really helped us a lot in developing these and gave some interviews to be represented in these videos, as well as some opportunities for self-reflection for the research team. And then we're going to be holding an in-person session with some didactics and some role-playing with simulated patients, as well as some group discussion. And we just scheduled that for May, so this is all very much in progress. And then we'll be doing individual follow-up with each person who's participating. You don't need to read this slide, but this is just to give you a sense of what our performance objectives are and how they kind of span, initially in terms of people's partnership with the clinical team, with bedside nursing. These items 3 through 6 are really focused on that initial connection, so getting the family's names right, empathizing with their experience, addressing other needs outside of research. And then 7 through 9 is really focused on the consent discussion, the building connection phase, talking about why the research team cares about this project, what the benefit is for future patients, and really exploring people's options for participation. And then finally, continuing that ongoing connection with the family. So we, as I said, we are going to be implementing our educational intervention in May. We have a pre-post design for the study, so we are currently in the pre-phase right now. And we're looking at a variety of different outcomes. So we'll be looking at enrollment rates and disparities in enrollment among infants. We'll also be collecting family experiences using surveys and interviews about how they experienced these interactions, whether our intervention made a difference in their experiences with members of the research team. And then we're also having the research team members report on their own achievement of these performance objectives using a milestones-based self-assessment tool. And we are also externally validating that tool by audio recording some of the consent discussions. This is another busy slide, but this is just to illustrate how all of our outcomes fit together. So you can see right here in the middle is our educational module. And then at each of these stages, we're looking at all of these outcomes, both before and after that intervention. So we're first asking looking at EHR data to see if this changed enrollment rates and if that varied across different categories of infants. In our surveys and interviews, did this change families' experiences of recruitment, and did families feel more respected? In audio recordings of the researchers' interactions with families, did this change research team member actions? And then in the self-reports of milestone achievement, did this change the research team's perceptions of their ability to achieve these milestones? So as I said, this is currently in progress, so I don't have results to share, but we are really hopeful that this is going to be a way, and so far it seems to be feasible to implement this into an ongoing study. And we're hoping to see some positive outcomes in terms of the impact on families' experiences. So let's see, I think I'm right on time. Great. So a few takeaways, kind of bringing everything together from today. I hope I've emphasized that respect and relationships in research are really interrelated. We need to be thinking about these hand in hand, and by taking a relational approach to thinking about our interactions with families, I think we can work toward a place where research can become more trustworthy over time. Respectful relationships can be supportive of promoting autonomy, as well as making research more inclusive and advancing equity in clinical research. And as we think about these relationships, we need to be thinking both on the individual level and the organizational level to think about the roles that individuals, as well as the structures that they're a part of, can play in improving these relationships. There's a lot more work that's needed to be done in this space to develop best practices for developing respectful research relationships. There are gaps in trainings. As I said, this is not something that people get trained in doing. There are not a lot of systems-based interventions that address these things, and I think there could be a lot more work there. And there's not a lot of evidence of best practices. And so our brief study is one effort in the neonatal context, but there are a lot more research contexts and a lot more work that can be done. And our hope is that we can eventually adapt the brief module to other research settings and explore how that can support decision-making and support relationship building across different settings. And of course, these individual relationships are critical, but they're not the only thing. And we all have a role, no matter whether our role is as a frontline person doing the consenting, or a PI developing a protocol, or somebody working on the IRB reviewing the protocol, or somebody supporting the research, helping get the reimbursements paid. All of these stages of the process have a potential role to play and have a potential impact on participants' ability to experience a respectful and equitable research interaction. And so I think we need to collectively and individually do a lot more thinking on the structural, institutional, and even the societal levels. And so be thinking about different ways that we can try to incorporate this idea of the culture of inclusivity and the culture of respect into all of the actions that we take. And so with that, I want to say thank you all for being here. Please feel free to reach out to me with any questions, and they told me to put this up here, and I will be happy to take any questions from the audience.
Thank you for your talk. That was just excellent. I had a question about how this might apply to assent. So at our institution, I think it's 8 and up. In addition to giving caregiver or parent consent, we need to get child assent. And so any thoughts about that or how that relates to some of the concepts we talked about today?
Yeah, that's a great question. So I'll just repeat. I don't know if people can hear, but the question is, how does this apply to assent? I think that's a really great, I was not as explicit as I should have, but I think about consent and assent as serving pretty similar purposes. Obviously, one is legally binding, so they are different in practice, but I think an ideal assent process is one that does a lot of the same things as the consent process, which is to make people feel informed about the study, to set expectations for the study, and to begin building that relationship between the participant and the research team. And so for the child who is providing assent, that relationship is just as important, perhaps more so, as the relationship with the parent or the guardian. And so, and actually, I'll as an aside, when we were doing our interviews with research staff, not very many people really distinguished between the role of between their interactions with the family and their interactions with the child patient. They really kind of talked about them all collectively, recognizing that oftentimes, most of the time, probably all the time, these decisions are made collectively, or at least in an ideal state can be made collectively. So they didn't actually really distinguish a whole lot beyond kind of saying, in addition to talking to the parent, I make sure that I get to the child's level and talk to them and look them in the eye and have this conversation with them as well. I do think that our intervention could be adapted to, obviously in the NICU context, we're not getting assent, but I think it could be adapted for a setting where we're getting assent, and particularly with adolescents. I think this would be especially important to focus on that relationship building process. And I think it could look pretty similar to how it is now. I think we'd need to do some preliminary research to make sure that we're understanding the unique factors for whatever study we're in or whatever the specific patient population is. But I certainly think that something like this could be a tool that could be used with children as well. Yes?
I really like the brief intervention. That's the fact that you get these 10 measurable parameters that you're working on. Do you have any, and then you have the next slide shows sort of how you're going to assess. Do you have any guesses about what part of that whole process is going to be the most impactful, or would you even be able to judge that?
Yeah, so we've designed our measures so that we'll be able to tell which of the performance objectives are being met or not met and which ones are impactful. So we have in our surveys and interviews with families, we're asking specific questions that map onto each of those objectives, and similarly, the milestones that we're asking the research team to respond to map onto each of those objectives. So the goal is to be able to tell which ones are having an impact. I don't, so far they're doing a pretty good job of recruiting. So we'll see how much of an impact we're able to have. Yes.
Going back to the slide that you had regarding decision timing to participate or not participate, and at what point people decided, I guess the question I have is, what evidence do you have that the concept of respect and trustworthiness has an influence on the non-participant decision making? So, you can look at those people who decide to participate because they're engaged with you. How do you look at the people who decide not to participate?
Yeah, and I think that's one limitation of that particular study. So people who declined to participate and then completed our survey are perhaps not representative of those who declined to participate and then did not complete our survey. And I'd have to go back and look to see exactly what our response rate was. But so that is a limitation, and it is always difficult, kind of across the board, to recruit people who decline to participate in this kind of research. That said, one of the main themes that I hear over and over when we do talk to people who decline is that they just didn't have time or the burdens were too much. It's not always that. Only sometimes do we hear things about not trusting the research team. Maybe they're not willing to tell us that. But a lot of times it's related to, I work an hourly job and I can't cut my hours in the middle of the workday in order to come in and do this research visit that's going to take an hour drive and then an hour visit and then another hour drive home. And in the meantime, I have to arrange for my kid to get picked up from school. So it's that kind of thing that we hear. And in that particular study, that was a health intervention study that required a relatively large commitment of coming to kind of group meetings so the time burden was a real thing for people, and that certainly affected people's decisions. Yes.
Knowing that you've become a research coordinator, and one of my teams I'm on, we have two research coordinators. One is an MA trained, and the other is actually a physician trained in Iraq. So I think it speaks to the range of what you can get coming into that position. Retention of research coordinators as a whole has been extremely difficult over the last couple of years since the pandemic started. And we definitely have recognized retention impacts how those interactions go with the RCs or with the families. And you mentioned kind of a little bit about institutional and policy change. I'd like to see them get paid more to help that retention as well. What have you guys been successful with policy and institutional change from where you're from, as a place that I think has a very good reputation for doing clinical trials and clinical research?
Yeah, that's a great question. And I think you're totally right that paying people more, because the reality is that industry can pay people a lot more than academia. And so we need to make sure that we are doing our best to keep people, people who do really good work. And so I think ultimately that's one of the most, I don't have data to support that offhand, but I think that's a key way of retaining people. I think we can also be thinking about making sure people have career development activities that are meaningful to them. One of the things we heard from some of our participants was that people who were bilingual were often pulled primarily into research participant-facing activities and not given the opportunities to really develop their skills in other areas, even though that might be something they wanted to do because they were so needed to do those interactions. So thinking about making sure we provide career development activities in an equitable way, and making sure that we're recruiting enough people who are capable of having those interactions in multiple languages and with the languages that folks in our clinics speak. I was going to say one other thing. So what kind of policies have we been effective in changing? We've done some work actually with our IRB to try to simplify some of our consent templates and to translate those, at least to translate the boilerplate language into the most common languages at our organization. And that, we just recently launched those, and that's, I think, had a little bit of an impact. Hopefully made some people's jobs a little bit easier. It's made my job a little bit easier at some times, but I think there are still a lot of barriers, and it's kind of an ongoing process. You have do a lot of this work to kind of change things on a policy, lowercase p policy, institutional level, policy level, and you still run into lots of barriers. And so, if you aim for here, you might end up here. So those are some of the things that we're working on.
Got it. Thank you.
Oh, yes.
We have a question from the chat here. So it says, great talk. Your qualitative data describing research participants' perspectives seem to mainly include participants who identified as white or Asian. Are you expanding this work to include other racial and ethnic groups who have historically not been represented in clinical or translational research?
Yeah, great question. So I realized I only included a demographic slide for the interviews with research coordinators. So those were the coordinators, and those demographics are largely representative of the staff at our organization. In terms of the participants that we spoke to, so our the interview study with research participants was based in a larger study, and so that was a study that had primarily Hispanic or Latinx participants, as well as white identifying participants, and so those were the main racial and ethnic groups in that study population. But the point is really well taken, that we really need to be, this work needs to be representative of the people who we're reaching out to, and so yeah, excellent point.
I'll add on to that. In your review of the literature or in your work, do you think about unique things that we should be doing with certain populations, maybe who have had, we're talking about that society at large and the collective kind of, larger entities that inform research participants' decisions? Are there unique considerations for certain populations that maybe have had worse experiences in the past with research?
Mm-hmm. Yeah, one of the things that the coordinators in our, in our research staff interview study talked about was, how to address the long legacy of unethical research and racism in medicine in the context of a research interaction. And so some folks talked about bringing those things up and acknowledging them up front, and some people said, I don't know how to unpack that in 20-minute conversation with somebody. And so, there wasn't agreement among research staff how they approach this, how they approach that. I think certainly there are going to be people, people have different lived experiences based on how they're treated in society and the sociocultural groups that they are a part of. I don't have answers as to exactly what the specific approaches should be, but I think this is a place where really robust community engagement, going back to that very first slide from Dr. Wilkins, talking about community engagement. I think probably some of her work is really important, and the work of people who do really deep community engagement work is going to be really important, because ultimately you need to know your study population and the people that you are trying to recruit and the unique things that they're facing, whether societally or clinically or realistically, both of those things.
Thank you so much.
Well, thank you all for being here.